Awesome. Well, welcome everyone tonight to our final webinar series in our Rush Get to Know Our Rush EM program webinar series. Today we're going to be talking about our social and community and global health track and some of the outreach programs we have here at Rush. So thank you everyone for joining us. I know ERAS finally went out and you guys are still here, even though applications have gone out. So thank you. I'm going to let everyone, our panelists and speakers tonight, kind of go ahead and introduce themselves, and then we'll jump right in.
Well, welcome everybody. My name is Braden Hexum. I'm the Residency Program Director. I want to welcome you. For those of you who have been through all of these with us, thanks for hanging in there to the very end. This has been really a great experience for us and has helped us showcase a bit about Rush. And I'm really excited to talk to you more about some of our social and global emergency medicine programs that we're doing. As somebody who has done a lot of this in my past, this is a passion of mine, and I think that we're going to hear some great stuff. So thank you all, and looking forward to hearing your questions.
I can go next. I'm Harrison Pigeon. I'm a second year at Rush, obviously. I'm one of the participants in the global and social EM track, so I can answer from a resident perspective, me and Kea. I thought I saw Nooper on here.
I think she's trying to jump back on.
Oh, okay. All right.
And then we have Dr. Ansari and Dr. Desiyanke.
Vinu, do you want to go? I know. I was like, which one of us is going to talk first?
No, I was like, I'm gonna.
You go first.
Sure. So I think both Dr. Ansari and I could probably talk at the same time because we have the same level of commitment, I think. But we kind of developed this social global emergency medicine track. Was it, what, a year and a half ago or something? And it's a track that allows you guys to kind of delve more deeper into some of the social issues that we deal with here in Chicago locally, also nationally, with some of the policy stuff that Sophia, Dr. Ansari does. And then also we have a global track, so some global projects. So I'm Dr. Desanker, Dr. D, I go by Vinu as well. And I did a fellowship in toxicology after completing my residency at Cook County Hospital. And then also that fellowship was also, that was like a hybrid where I also did international global health. So I got my MPH at that time as well. And then yeah, I went back to California for a bit, came back to Chicago. I think Chicago draws me back because of all the social issues that are here. It's kind of a weird thing to say, but at the same time, it makes me feel like maybe there's still work that needs to be done, and it's good work. And so that's kind of what drew me back. So yeah, let Dr. Ansari talk.
Yeah, thank you for that. And I actually started my career as an international EM fellow as well. And so I received my master's in public health at UIC down the street. And over time started to feel like I was seeing the same issues in Chicago and in our country that I was trying to solve in other places. And I was like, I can't try to fix other people's health systems until we fix ours. And I really believe in the physician as an advocate. I think we should be proud of what we do in the clinical arena and really take some of those skills out into the community and speak up for our patients and our colleagues. So I'm really excited to be here. Thanks so much.
Thank you. And then I'm Kea, one of the third-year residents. I'm, like Harrison said, I'm one of the members in our social and community global health tract. And then we do have another resident who will be jumping on shortly, Dr. Nooper Shah, who's also a third-year resident, and she's been pretty heavily involved, and she's going to talk a little bit about her human trafficking efforts here and getting us trained and, helping to identify possible patients and victims of human trafficking. So as soon as she's able to jump on, we'll get her input on that as well. And I kind of just wanted to start off the discussion about what we talk about, a lot of the social determinants of health and why as emergency physicians, it should matter to us and what we can do while we're in the emergency department to kind of help battle those issues and why it's important we know them. So if any of the attending staff can talk a little bit about that and why as emergency physicians especially, it's important that we're cognizant about these detrimental health effects.
I think one thing for for me. So I've been practicing since 2006. And what I, you know, how many of you guys feel like you talk to patients and you kind of start to hear the same stories over and over again? You know, I'm here because I'm not taking my medications. I couldn't get to the doctor. My doctor keeps switching because my health insurance keeps switching. And, you know, the first few years of practicing, I was really frustrated by these problems. And I was doing something really terrible where I was blaming the patients, and it was not allowing me to provide them good care. And it was I was not being the kind of doctor that I set out to be. You know, when I applied to medical school, did med school, I mean, all this work that you all are putting into this, right, to help people, and I was going down the wrong road. And I think, like, I started to look to my colleagues who you know are great people, and you know, we started talking about all of these challenges that people are facing. You know, what are they? Are they personal or are they structural? Are they institutional? Are they policy based? And when I started to look at it that way, I started to see so many similarities. And I was like, wow, if I could just try to identify these issues and start tackling them, you know, lack of insurance or just being underinsured, transportation issues, food deserts, homelessness, you know, gun violence, trauma every single day, you know, stressors that people are dealing with. I was beginning to realize that these were just as important, identifying this, as doing the heart score to figure out somebody's risk for cardiovascular disease, you know, putting somebody through the Wells criteria and PERC to figure out their risk for PE. You know, this was just as important, because, you know, it didn't matter if, like, I gave you the prescription for Eliquis for your you know, clot. If you can't get to the pharmacy, can't get the prescription, can't continue taking it, and can't get to the doctor for follow-up, my job can't happen. I can't do my job without addressing social determinants of health.
Thank you, Dr. Ansari. That was fantastic. I don't know if anyone else has any comments on that.
Yeah, you know, I listening to you kind of mention what it felt like to have this reaction towards the patients in which we were caring for. It's hard because I felt the same way. You know, it's you have these frustrations and they happen over and over and over again, and but it's different patients every time. But to us, it seems, you know, very similar. Why am I still taking care of these same challenges every time? I mean, part of it is I chose emergency medicine, right? I actually kind of knew going into it that this was going to be, you know, some of what I was going to be faced with. I chose emergency medicine because those kinds of problems and helping to work on those, it was something that I thought was important in my identity as a physician, you know, and so choosing where you go for residency makes a big, it makes a big difference in how much exposure you have to those challenges on a daily basis. And I think Rush especially is a great place for that, because we are at this nexus of so many of those interactions at the physical location of where Rush is in the medical district in Chicago. And where so many of those different communities come together and intersect. It's just a fascinating milieu to actually practice on a daily basis, much less talk about some of the interventions and community programs that we've got. Just every day I come in and have to deal with this. And so it helps me feel like I have chosen a place in which I can actually have an impact. And that helps with some of that burnout, because even though I might not make a difference on any individual patient on some days, I'm at least, you know, trying to address them structurally within my institution.
Yeah, even as a resident, you know, recently, especially this past 6 to 7 months with everything going on with the pandemic, I've been finding myself, as I'm interacting with patients, asking myself, once I discharge them, then what? You know, a lot of times people come into the emergency department as a last ditch resort, as a last effort, because they don't have anywhere else to go. And I've started thinking about, well, I'm sending them back to that same condition. What can I do differently, right? Those are the conditions that's what sent them to the ED in the first place. And obviously we're not going to be able to fix every single patient's every single problem. I think, the nice thing, like Dr. Hexam said about being at Rush, is we have the resources, we have the multidisciplinary teams, and we have that nexus where we're located to kind of make an impact. And that's one of the things that really drew me to Rush before even, choosing where I wanted to go, was I knew they had such a big initiative with the West Side and all the resources and projects they were doing. So I really think this pandemic has opened up a lot of our eyes to the social determinants and the healthcare disparities. Even though we learn about these specific instances during medical school, I don't think we're taught enough about it. So I think, hopefully that's something that comes with a cultural and curriculum change. Harrison, I don't know if you have anything to add.
No, we've got plenty of time. It was well said by the previous people.
So
one thing, Kay, I wanted to say was I really love that Dr. Hexam and Dr. Heinrich and everybody in the residency has kind of incorporated this into the residency training. So one of the questions in the evaluations after a residence shift is, did the resident acknowledge or utilize institutional resources, things like social work or the chaplain, whatever we have, at our disposal at Rush, and we have a lot. And so this kind of integrates those services into your day-to-day shift work. So it's not like at the end of your third year, we're like, oh, wait, by the way, these are all the other things that you have available to you, sane nurses and all that stuff. No. Every single day is the resident cognizant of the fact that these resources are available, because then you'll go out into the world and then you're going to look at, your workplace and be like, do we have these things? Because these things are great. Why don't we have these things? This is important.
Yeah, thank you, Dr. Ansari. That's an excellent point. And so I kind of want to transition now. I know a lot of students have asked if we specifically in our program have a social, community, and global EM tract, and we do. So if Drs. Dissanayake and Dr. Ansari can talk a little bit about the tract specifically and some of our requirements and how the course is structured, and then Harrison and I can talk about our experience as residents going through the tract.
So yeah, I could talk a little bit about that. It's basically, I think Dr. Ansari and I kind of realized there are these common underlying themes when it comes to social medicine or social emergency medicine and global emergency medicine. Mainly those underlying themes would be the social determinants of health. That we see those health equities nationally, locally, and also globally. So how can we close those gaps? And also how can we educate our residents so that they are the burgeoning leaders when it comes to going out there and fighting the good fight? And so we decided, let's do a track where for 3 months, we do social emergency medicine. And like the last piece that we did with Dr. Ansari was on homelessness here in Chicago. She did an amazing job every month with new resources and new projects that the residents kind of did together. And then the next 3 months would be global emergency medicine. So I'll be introducing a little bit of Africa the next 3 months. And then the following 3 months will be back to social emergency medicine, and the following 3 months, another World Health Organization territory. So basically, by the end of your residency, we're hoping that you'll be seeing 6 different social emergency medicine issues in very in-depth manner, learning from each other in an interactive manner. And then also you'll be traveling the world and learning about parasitic diseases, learning about the health equity issues around the world, and finding ways in terms of like community participatory kind of methods to kind of develop projects. That's ultimately what we'd like you guys to kind of learn is, now that you see there's a problem, how would you go about solving it, either as a research kind of thing or as a policy kind of way. So that's kind of the gist of the track. Dr. Ansari, anything you want to add?
Yeah, and up until the pandemic, we were doing some in-person didactics, a lot of it virtually. We use a platform called Canvas, and that Dr. Dissanayake is like really, really good with. And but since then, we've kind of switched a little bit more to virtual, but we try to make it as multidisciplinary for our participants. So there's topics are within, for example, social EM, there'll be personal YouTube videos. There will be articles from a variety of journals, not just medical journals, discussion points and things of that sort. Yeah.
Thank you, guys. Sorry, go ahead, Dr. Nixon.
And while it's an optional track, I do think that the majority of residents at some point in their course of their residency interact with it to some degree. We recognize that, you've got a lot going on. There's ICU and trauma and a lot of other rotations to get done and a scholarly project. There's a whole lot of tasks involved with 3 years of residency that there are going to be times when you're not going to be able to be engaged in this. And so that's why it's helpful to have it, where it's more of a choose your own adventure, that as you kind of have time to engage, you can do it. And then when you're not able to, it's okay. And so I think that, there's a question earlier is like, do most residents get this? They do, I think, to the degree that they feel invested in it. And not every resident stays in the track throughout the whole 3 years. It changes as their interests develop.
Yeah, that's true. I mean, in terms of the track, we make it so that if you do 50%, just half of the whatever we have given out, you would be like a pass. The pass doesn't mean like a grade per se, but it's just a certificate you get at graduation that you completed this kind of course. And then, people come and go as they please. I remember there was one session where 2 residents didn't even sign up for the session, but they're like, oh, we just wanted to sit in, and then they came the next time too. So it's, it's just, whatever floats your boat. If it's something interests you and you want to show up, you can show up. If you don't, no one even is, is counting, so to speak. It's just whatever is interesting you guys, because that's what you guys are adult learners, what you're interested in, what you'd want to do. And we don't want to, try to like force something down your throat if you don't want it, but it's just an option. So.
And occasionally our participants are the experts on, no one person is an expert on this. Like it's a very, everyone participating. Some people know a little bit more about certain things. And we take a lot of feedback, and, the track has evolved since it started, even though it's only just been a year and a half.
Yeah, and I think Braden touched on it a minute ago, but for residents that are not like in the track, it's not really so set in stone. I guess Kay and I say that we're in the track because we go to all these events because we like hearing and learning and participating, but there's no official like, if you're not in the track, you can still participate in any event, and then, or any educational thing. And then one of the awesome things about Rush, somebody mentioned earlier about how we're a pretty well-resourced hospital. And we rotated other hospitals which have different levels of resources. And so one of the things I love about the Rush Emergency Department is I feel like if I try hard enough, I can almost always do the right thing for the patient, which does not happen at every hospital. Sometimes you literally just have too many patients and you can't sit on the phone for 15 minutes to call different shelters to say, look, I know your policies in general, but do you have a bed open tonight for this person who has this special situation or something? And so our 24-hour case manager and social workers, they do cover like the whole hospital when they're overnight and on weekends, but otherwise they sit in the emergency department. So, I'm on a first name basis with most of them because at least once a shift, I would like their help, at least to offer resources, to kind of be a resource that's not a part of their clinical team. Because sometimes I have to separate myself from like a patient's like medical care from their like other social needs that, I might press some buttons by kind of pushing them on like their drug use and like, if they're ready for detox. But then if I send somebody else in to just like ask, hey, have you thought about detox? Have you ever been to one of these places that's in walking distance of here? That's like a huge resource that any resident and any attending and any worker can use.
And kind of touching base, someone had asked a question about, those residents who don't elect this tract, do they leave Rush with an adequate sensitivity to these kinds of issues? And I think we do. And a lot of that comes from also doing months in the ICUs and doing months at away sites and the community centers we rotate at. And you really learn about inpatient medicine when you're in the ICUs, coordinating care, making sure, hey, if they need prescriptions filled, you go to the pharmacy, walk over the prescription, pick it up for them and give it to them. So when they're getting discharged, they have those prescriptions at hand, setting up their follow-up appointments and making sure they even have transportation available. As emergency physicians, we may not necessarily be doing all of that because we have such a limited interaction, but I think the inpatient months we do have really solidifies that continuity of care. And being at Rush, we have such a diverse patient population. Everyone has such different needs that we're really able to work with our multidisciplinary teams to get that aspect. And even being at Cook County and at Mount Sinai, very different hospitals, very different level of resources. And I think that kind of just gives us a well-rounded experience, because not all of us are going to stay in academic medicine. We're not all going to be at a big tertiary care center. So I think one of the biggest things that this track has changed about my residency experience, going to this next question, is how empowered I feel after graduating from residency with the resources that I know that I now have, right? In our last track about homelessness, we had kind of come up with a list of resources and what are the best places, and whether it's for LGBTQ or whether it's for women's shelter and whatnot. So these little things that I learn and ideas I get from interacting with my colleagues has really empowered me to be like, when I go outside of a big tertiary care center, I can still provide my patients with those resources.
There's been a couple questions kind of about community partners and engaging the community and sharing that their voice is heard. I think I can speak to this pretty well. I went to med school at Rush, so this is my 6th year at this institution. And even though our residency program is new, Rush is not. So Rush has been around for over 100 years. I forget what year it was founded, but it's like a staple and an anchor institution on the west side of Chicago. So fallout from that means that they have long and well-established partnerships. There's a couple full-time workers at the university that just specialize in community outreach, and they help to coordinate different sorts of events throughout the year. Specifically, another big one would be Westside United. It's a collaboration between a couple of different health institutions in the city. Rush being one of the main partners, their goal is to reduce the health gap that exists right now between the Loop and the far west side and the far south side by 50% by 2050. So one of their big things, they started in the last 3-4 years or so. Yeah, 3-4 years. And so they, had used the community health needs assessment that Rush as a university has to do anyway, in combination with the other health needs assessments that the other hospitals had to do. To kind of say like, okay, what are the stakeholders and what do they want? What do they need? And listening to them first. And then they wanted to have a tangible goal. So that's why Westside United has this, benchmark to say like, are we succeeding? Are we not? Because, everyone wants to do good. That's anyone in medicine, you at least at one point had the right reasons at heart. And so everyone wants to do the best that they can, but to be able to have like quantifiable measures is an important thing to keep you honest and keep you accountable. And then there are, COVID has definitely changed a lot. So some of the, yearly events that Rush has done for like literally decades were not done this year. So we have a pretty close relationship with Crane High School. Robert T. Crane, I think is his name. It's a medical preparatory college public school. And it's literally on like the other side of the highway from Rush. You can walk there in 5 minutes. So we do a lot of mentoring with them and different kind of like exposure days just to get kids interested in STEM. I mean, they're already at a high school that gives them specific like medical preparatory classes. They take like forensics and anatomy and different things. But so that relationship is like pretty well established and has been for a long time. Then there's a few school-based health clinics. I think there's 13 in the city. Rush goes to 2 of them. They send med students there to kind of help educate. I can keep talking forever about this, so I'll stop now. But just to say that, the emergency medicine residency is also a part of this. So, we regularly will volunteer these events, and kids love learning about like how to do a suture repair, which is like, we do this every day. So as a 4th year medical student, you could teach that class easily. So yeah, that's some
One of
part.
the other big ones that our residency specifically is involved with is with the Night Ministry and the Street Medicine Project. So basically, it's a clinic on wheels per se, and there's a social worker, and you as a resident, there's the on-call doc who's the attending, and usually a medical student. On Saturdays, we go out into the West Side community mostly and help take care of the homeless people, right? We do wound checks, wound care, dressing care, refill medications, do blood pressure checks, sugar checks, and just kind of basically check in on them, provide them with social services. We pass out lunches, we do warm clothes and blankets and things like that. So that's a really, I just did a run a few weekends ago, and it was such an awesome experience just because you really get to kind of go out into the community rather than taking care of the patients who come into the hospital in a vulnerable position. You go out into the community and really see what it's like. So that's with COVID, that was kind of put on hold, and recently we have restarted it. So I don't know, we'll see what happens with rising numbers now, but hopefully we can continue that going. And then there was another question here, kind of briefly mentioned about the LGBTQ initiatives at Rush, and someone had asked, is there an option to focus on LGBTQ health? Interestingly enough, we do have a curriculum within our residency. It's called the DIRE curriculum that Dr. Desayange, Dr. Ansari, everyone on here today kind of helped develop. It stands for diversity, inclusion, and racial equity. And it's a 3-year curriculum into our residency. And I'm actually going to help develop the Latinx and LGBTQ curriculum for next year. So yes, there will be opportunities to learn specifically about LGBTQ health and get more involved in that. So stay tuned, more to come.
This is something that, even all of our residents will be exposed to. Rush has been out front in LGBT health, for decades. The rumor is that we were giving same-sex benefits and civil union benefits in the 70s when this wasn't even, a consideration in most other companies. I don't know how, I've validated all of that, but the institution itself prides itself on its care and its inclusivity. We have one of the only gender affirming clinics and centers for surgical options. It's a place in which, as a resident, you are going to be exposed to this whether you have had experience or not, and we will make you great at being able to communicate with people who don't look like you, who have different backgrounds than you, who have had different routes towards life, and you'll be able to communicate with them because you have to take care of them. This is the kind of emergency department that you're going to see that kind of care, and people who are along that spectrum of transitioning through our clinics and the providers that provide care are also included in that group. So we recruit on this. I think that we do very well, and Rush is known for that.
I want to throw something in. I had an interesting patient. No, it wasn't even necessarily an interesting situation, but I had a transgender patient like 2 nights ago who, when I asked his gender pronouns, he told me, and then I was like, well, your legal name is listed as something else. I'm going to try to change it. And I had registration change it in 10 minutes. And I have done it before. I think it was just like a convenient time for registration too, but it was very satisfying, at least for me. I have no idea how the patient feels, but I was so happy that it was quickly fixed. So that means that it's less likely that they're going to be misgendered as long as that he's in the healthcare system for that day, as well as any future visits, which is great. So yeah, that just triggered my memory.
Yeah, and in Epic, even the EMR we use, I think we've really focused on making sure we have the appropriate pronouns that patients prefer to go by as well as their name, which I think really makes a huge difference with that first interaction you have with the patient. You're able to actually address them the way they want to be addressed. And I think that goes a long way in establishing good rapport. There was a question about health advocacy and legislation. I don't know if anyone has any experience with that specifically at Rush, or we can.
Yeah, I gotcha. So Rush is pretty involved with ISEP, which is the Illinois chapter of emergency physicians, ASEP's state branch. And so, we have one of our doctors who works in our administration for the department, Dr. Purim, used to be the president like a few years ago. So we are well tied in with the state chapter. And every year they go to Springfield, which is the capital of Illinois, not Chicago. So a couple hour train ride. I've been 2 times now, actually. And so just to say that there are people here, I know that Dr. Purim is always keen on trying to find somebody else who will like really take it to the next level for our legal and advocacy perspective. And we haven't talked about the ISEP social EM webinar, which finished today. So briefly, it's not necessarily a Rush specific thing, but many members on the Zoom and in our hospital helped to kind of create this 4-part webinar. The last one was earlier today. And one of our attendings, Dr. Amita Shah, she spoke on it about advocacy, especially through writing op-eds. So if you Google, Amita's not going to care, it's fine. If you Google Amita Shah Rush or MD, she's like published in a bunch of different places, some like online forums like Kevin MD and Slate and stuff like that. And then others, she's been in the Chicago Tribune and yeah. So feel free to look her up if you'd like, but there's definitely people in our department that are interested and willing to support and mentor people that are interested in that.
Yeah.
I wanted to comment. So I'm one of the 3rd-year residents here at Rush. My name is Nupur Shah. So I wanted to echo what Harrison said. I feel like Rush really cares about the advocacy piece. And if you look at the board of directors for ISEP, it's predominantly made up of Rush faculty. And our medical director, Dr. Dino Romero, Dr. Ed Ward, who's also like one of the part of the leadership team, and Dr. Yavina Purim, all of them served as former presidents of ISEP. And then Dr. Ansari's on the call. She's on the board of directors currently, and I'm actually the resident member of the board of directors for the state of Illinois. So there's significant Rush presence on there. So I can talk a little bit about my journey. So as an intern, I was really interested in advocacy. Our leadership team picked up, I was really interested in this. And so I gave a talk at first year residency at ISEP on human trafficking. And that after that, I started getting more and more involved and learning more about human trafficking and like how prevalent it is in the Midwest. And I just recently, in the last 2 weeks, after about 6 months of work, put together a training to offer to anybody and everybody that works in the emergency department, whether it be nurses, physicians, echocardiogram technicians, security, registration, to train everyone on what are red flags of human trafficking. And that was because of my advocacy piece that started intern year. And so I think there's just so much opportunity here at Rush. If that's something that you want to pursue, there's a lot of support. Everyone on the faculty, a lot of members of the faculty have done things like this, including our program director, Dr. Hexum, has been really involved with the advocacy piece and part of his career. And so if that's something that interests you, they will encourage you to and put your name forward for opportunities like that.
And that's something I'd like to say too, is like anybody that comes in, if they have an interest, they come in and say, hey, I want to do this. This is my passion. We will find a way to make that possible for you. I think Rush has so many resources that it would be hard not to, we'll be able to pull whatever you need and make that happen. So yeah, we're very proud of Dr. Shah. Nupur Shah for doing all this great work in human trafficking, and it's going to carry over. What she's doing is actually becoming a movement at Rush. We're going to be able to spread this along to other departments and even to other Rush hospitals in the area. So it's really meaningful what the residents can do at Rush.
This parallels the mentorship webinar. So after this, if you haven't, you should go back and check out the mentorship webinar that we did, because this is really what we're talking about. Whatever your niche or interest might be, we've only got 3 years with you. That goes by really fast. And so the way in which we've structured the intern year, where we get to know you really early on by having you do a lot of ED rotations, that actually helps you get to know our faculty and how our faculty get to know you early on, so that we can actually focus on how can we build your CV to get you what it is that you want to do. You are not going to be an expert in all of your career goals at the end of residency. You're going to be an expert emergency physician, but are you going to be, do you have enough skills? Do you have enough mentorship to be able to go out into the world and do whatever it is you want to do later, which is maybe that's advocacy, maybe that's a global or international emergency medicine fellowship. Maybe that's to, do some additional leadership roles within administration. So I want to help you get to that. And part of that is getting to know you early on in your residency and finding you the right mentorship. And we've got some really great mentors on the call here who have, I think, taken that role on and have helped our residents get what they want out of it.
I also wanted to add that Dr. Hexum does a lot of really great work with refugees. So he actually has provided a lot of experiences to our residents in that. Could you talk a little bit about that, Braden?
Yeah, I initially started my career thinking I was going to do global emergency medicine. I spent a lot of my 4th year of residency in Liberia, helping to build an emergency medicine infrastructure there and teaching with their medical school. And I actually thought that's what I was going to do. I got involved in a human rights program in Queens, New York, where I had done residency and worked with our residents and the medical students there to build a human rights program. And that, it changed as I got more interested in mentorship and in infrastructure building and in working with residents. And so I don't do as much of it anymore, but it was one of the things that as we built a new residency program here at Rush that I felt was absolutely important. So while it wasn't necessarily the first thing that you think of when you start a new residency program, having the opportunity to learn about social and community issues, disparities in medicine, this was part of, some of the founding ideas of our program. So it's why I think we've done really well building this up in a very, very short time.
Thanks a lot for that, Braden. I wanted to say something and then answer one of the other questions. So, social and global emergency medicine is an enormous topic that touches on so many different things, and many people have their own kind of passion within that niche itself. And so it can be kind of hard to have a full conversation about all of these super important topics. So feel free to reach out to any of us on the panel if you have further questions about anything specific. One of the things that was asked about was about X waivers, MET training, and that actually answers another question, which was, what's the biggest challenge and how has Rush responded? So there are a lot of challenges that people in Chicago face. One of the things that I feel like I see every day is drug addiction, alcohol, and also heroin. So Chicago has a huge heroin population of folks addicted to heroin. And it's pretty cool being in a new residency program that's pretty forward thinking. So as part of your tox rotation, you have to get X waivered if you're not already. And then Henry Swoboda is one of our toxicologists, and he works mostly as an addiction medicine doctor, but he is super well known across regions. And if you talk to many people that are addicted to drugs that have been hospitalized in Chicago, they know Swoboda, which is kind of fun to think about. And so he has made it a point to make sure that a lot of our attendings are also X waivered. And we have a 24-hour addiction service that if there is not an attending that is X waivered, you can FaceTime one of either a toxicologist on call or their advanced APP, like a PA or an NP, and they will get that patient Suboxone. So I've actually done it a couple of times. I felt so bad one weekend. I called the APP 3 times. It's like Friday, Saturday, and Sunday nights. But I mean, they're very responsive and easily available. Henry made an offer, Svoboda, at the beginning of my intern year last year, of anyone who comes by the clinic, you can just pick up naloxone. And I was thinking about it. I was like, why do I not carry naloxone? If there's anybody who would like feel comfortable using it, it's me. And like, I don't hang out with any heroin users, but I also commute to work and I take the bus and I walk some of the way. And I mean, it doesn't make sense for me to not have it. So now I carry naloxone.
I wanted to echo what Harrison said too. I feel like working at Rush, being a resident at Rush, I just feel like we having things like the addiction service, the 24-hour, 7 days a week addiction service, and just after finishing the tox rotation myself, tox/addiction, I just feel really good about the care that we give at Rush. Like I feel like our patients are really well taken care of holistically, and all of their issues are really addressed while they're admitted into our hospital, whether it's their drug problem, somebody goes and talks to them about their drug problem and how they meet them where they're at and help them kind of achieve their goals. And that's something I feel like that's just something really rare these days, to, feel really, really good about the care that you provide. So I think that's just like one of the mottos of Rush, to include that. And that's been kind of like a C-level priority that's been echoed down all the way down to the emergency department.
And I think in addition to, sorry, go ahead, Brandon.
So the addiction program is actually it's a required rotation. So while you're on toxicology in your 3rd year, you will actually spend time doing addiction medicine with our, we call it a SUIT consult, substance use intervention team. So you'll actually be rounding on the floors, patients who are admitted, who have dependence issues in the clinics. You actually get exposure to this. As a emergency physician, being interested and working on healthcare disparities is a really frustrating niche to get into, because you're constantly met with either disappointment that things don't happen the way you've wanted it to, or things aren't changing as quickly. It's a field in which there's a lot of burnout, unlike other subspecialties of emergency medicine, because so many of the stories that we deal with are disappointing and frustrating. But here's something where emergency medicine is actually really changing the story with addiction. The fact that we are out there actually making a difference in the opioid epidemic as emergency physicians, I think is really remarkable. And as I think helped me clinically to feel much more confident about the specialty that I have and the care that I've given. It's really great to be here at Rush, where those services are available and that we can draw upon, and you're going to learn those skills. So, it's one of the few times as an emergency physician who's at 15 years of practice to actually say, we're actually making a difference from a public health standpoint. And I think that will help us as a specialty in the next 10 years.
And to the attendings in the group, don't you feel like it has changed the stereotype? Like, I think that whole team has done an amazing job of changing the way that we engage and speak with and offer treatment to people who have, any type of substance use disorder. They've helped us change our language. It's amazing.
Absolutely. Yeah.
And I have to say that all of the people that I work with are very collegial. So I've never really had a situation, maybe a few times, because maybe it's because I didn't understand stuff when I first started. But I think overall, everyone's been very collegial. And if you have any question at all, people are very happy to answer and be available. They'll do whatever it takes for a patient. It really does feel like the patients are our priority, and we really want to make sure they're getting the best out of us.
I think as a resident, I really, some of the changes that I've noticed in my care is how I word things. Intern year, if I were to look back at some of my notes, right, it would be like alcohol addiction or opioid addiction, what now? And now after learning from all of these amazing people, going through some of our social and global community health resources, I've really come to understand, it's not really abuse. It's a disorder, right? Just like any other, and that's how we should be kind of addressing the issue. Is that, you know, as a physician, it's our kind of job to help them, and just seeing those different changes that I've been able to make as a resident has been pretty amazing. So I kind of want to just take a few minutes now to kind of transition to more of some of our global health opportunities. I know obviously with COVID and the pandemic, a lot of our global trips have been put on hold, but I know all of you guys, Dr. Hicks and Dr. Visayanke and Dr. Ansari, have been involved in global health as well. If you can talk about some of our previous trips, and what countries we've been able to travel to and some of the projects we've had, that would be awesome.
So yeah, we do have a global health, we have a couple of global health projects actually currently still underway. We did actually go to the Dominican Republic a few times. The first time was just last January. I went with Braden and we did a quick evaluation of their hospital. They had invited us as like consultants to kind of take a look at their emergency department and see what were some strengths that we could possibly provide to them in empowering their residency education. And we thought that after our evaluation that they actually have a very upscale emergency department, and it wasn't so much teaching them emergency medicine because they were doing a great job already with that, but it's more the other things like maybe ultrasound, maybe simulation, maybe some of these tools that we could help them develop in their residency education so that makes education even stronger. They had requested also toxicology. So they wanted us to come to give some lectures on toxicology. So that was the next trip. It actually ended up being, I didn't expect it, but it was at a 5-star resort and not expecting that at all. We ended up going there with me and one of our senior residents. Now she's graduated, but she got a chance to present in front of a very awesome crowd, a couple of important topics, especially bioterrorism agents and chemical agents. And so she did a fascinating job there. And then after that, we went, Braden, me, and Dr. Hawk, as well as one of our graduated seniors. Now she's out as an attending. Somi also joined us and we did a simulation assessment. And that trip actually was March 1st, which is right before, like right as we're coming back. I remember in the airport coming back from the Dominican Republic back to Chicago, we saw on our emails, Rush was saying, okay, nobody can travel anymore. So that was right at the point of that. But fortunately, they did love the simulation education and they want to incorporate that as well in their own residency education. The problem is now that we can't travel, we decided how can we make these projects more virtual? And so our next project is an EMS project. We're doing this with 2 residents. Kat Buckley is one of them who's here, as well as one of our Northwestern residents who took the global track, the social global EM track with our residents here. And so because she showed an interest early on, and one of my colleagues at Northwestern said, hey, can she tag along with you guys? So she did all the participation like everyone else and was able to earn the points to do that. And then we also have a Cook County attending. And then also, yeah, she's, why am I blanking on her name? But she's one of the biggest she was actually at today's ICEP. Hey, help me out.
Me?
Yeah, who's the attending at county who spoke today? I'm sorry, I'm so foggy brained.
Amira Hadid.
Amira, yes, Amira Hamid. So she's also part of that project. And she's an EMS director in Chicago, right, at Cook County. And so the 2 residents, her and I, are going to help with this EMS virtual education. And we're talking to the EMS directors in the Dominican Republic to educate the paramedics that are there. So that's something we're working on right now. The next project will hopefully be a simulation project. So we're trying to get that off. It'll be a virtual kind of deal. And then if we have time and if COVID goes away, ultimately we'll do an ultrasound project, it was the one that we were going to do right before COVID hit. We already have the ultrasound machine. It's at county and we've got it donated, thankfully, by, gosh, I keep blanking, the Mindray. So Mindray donated this machine. We're going to go down there with the machine the next time we can go, which I hope is soon. I don't know, it might probably be another year or 2, but ultimately we'll get the chance to drop that off and teach them how to do that. And they already have a toxicologist who is, an ultrasound person who is trained in ultrasound in the US, and they're going to go, they already have gone to Dominican Republic, so they're going to be the now the ultrasound attending, who will be keeping that going on as more of a longitudinal type of training program. So they might actually have the first ultrasound fellowship in the Dominican Republic. So that's exciting too. So these are some of the different pillars we kind of took on. There are other ways to do global health in other places, and I'm very open to that. So I know of another program through University of Miami. If you're interested in going to Haiti, certainly we could do that. We had already planned to do that right before COVID hit, so we had to cancel that trip. But that's also another option. And then if you guys have contacts or some interest in doing something, I'm very happy to try coordinate that for you guys.
I think the global emergency medicine development will change profoundly in the next year or two as a direct result of COVID. It's never sat well with me that it's very expensive for me as a consultant to fly to another country to help develop emergency medicine as a specialty in other places. Why are we not doing this virtually? And so we've actually, shortly after COVID hit, one of the first things that we started to organize, and Venu, you were part of this too, was a webinar to actually talk about our experience with COVID before they actually experienced it, where that to me is kind of the next wave of emergency medicine development around the world is going to be the virtual consultation. I think there'll always be a role for in-person teaching and for relief work on the ground. And thankfully, Rush Global Health, the larger organization of Rush Global Health, has been involved in the Dominican Republic for 15 years, building primary care services and surgical subspecialty services. The partner on the ground, Community Empowerment, is an organization directed and run by local community members in the Dominican Republic, and the services that we provide are at their request. So this is not us going to the DR to provide things that we think is the most important. They have asked us, these are services or areas of expertise that they lack that they would like us to come in and assist with. And in emergency medicine, that's EMS development, ultrasound, toxicology, of which, those services are still in limited development in the DR. So lots of opportunities to get involved, both actually going and also virtually.
Well, awesome, guys. Thank you so much. We're wrapping up here. I don't know if anyone has any last minute questions. If not, thank you again, everyone, for joining us. Thank you for all of our panelists and, of course, all the applicants. Good luck with everything. I know ERS is out. Enjoy the interview trail, and we are so excited to have such amazing prospective colleagues join the field.
Thank you, everybody. We look forward to seeing you here at Rush.
Thank you, everyone. Bye.
Thank you.
Thanks, guys. Good luck on everything.
Thank you.